Hello, my name is Nadine Ranger and I'm a pelvic health physiotherapist from University Hospital Sussex NHS Foundation Trust. If you are watching this video, you've probably recently undergone or about to undertake major gynae surgery at the Trust. This video has been put together to give you some information about the types of surgery and indications for the surgery. There is another video available that you can access that gives you information about post-op recovery. So let's look at types of surgery. So this stands for total abdominal hysterectomy, subtotal hysterectomy, and bilateral salpingoophorectomy. So what this means, total abdominal hysterectomy is the removal of the uterus or womb with the cervix. Subtotal hysterectomy is removal of the uterus, but with the cervix remaining. And bilateral salpingoophorectomy is both tubes and ovaries. So this operation is done through a bikini line incision in the lower tummy. And as I said, there's removal of the uterus, plus or minus the cervix, plus or minus the fallopian tubes and ovaries. And the common indications for hysterectomy, this type of hysterectomy, are generally heavy or painful periods, fibroids, and endometriosis. So let's look at laparoscopic hysterectomy. So this is total laparoscopic hysterectomy. So this is done through a laparoscope, so a small camera that goes through the belly button. And generally they're small incisions. Normally one, the laparoscope goes to the belly button, and possibly 2 or 3 smaller incisions in the lower part of the tummy. And again, the uterus and the cervix are removed. And the indications for this operation are generally either uterine prolapse or small fibroids. And the uterus can be removed through either small pieces through those incisions, or through a larger tummy incision if needed, or through the vagina. This is vaginal hysterectomy. So the uterus is removed through the vaginal space, and the ovaries are not usually removed. And a prolapse repair can be done at the same time if indicated. So an anterior or posterior repair, or both. So let's have a look at this slide. Quite a busy slide, but really it's just showing you indications of why you would have that type of hysterectomy. So let's look at, first of all, vaginal hysterectomy. So it's the first choice of hysterectomy if possible, but may not be possible if women have adhesions or have a large uterus. The middle one, abdominal hysterectomy. So that enables the surgeons to get a clear view of the pelvic organs and can be formed if adhesions are present or the uterus is very large. And laparoscopic hysterectomy, as we've said, a smaller incision which allows for quicker post-op recovery, less scarring, bleeding and post-op pain, and has a lower risk of infection and potentially a shorter stay in hospital than an abdominal operation. So let's look at vaginal repair. So we're looking at prolapse repair. This is an anterior wall prolapse. So if we have a look first of all of this little picture here, so just to orientate you, this is the pubic bone at the front. This is the spine, sacrum and coccyx. This is your urethra where you pass water and the bladder. This is the vaginal space here. This is the cervix and uterus here. And this is the back passage where you pass motion going up into the rectum and the colon. So if you have a look at this front wall of the vagina here, you can see there's a bulge here in the front wall of the vagina, and this is an anterior wall prolapse. So the operation is performed vaginally. There is an incision made in the anterior wall, so here, and then the bladder is mobilized back into a favourable position and then is stitched using dissolvable stitches on this anterior wall here. And usually the stitches take 6 to 8 weeks to dissolve. And as it says here, if a catheter is used, it is usually removed the following day, but not everybody has a catheter after this surgery. So let's look at posterior repair. So if we look at this diagram here, this is a normal vaginal orientation. So we've got the urethra and the bladder, and then the vagina and uterus, and there's the back passage here. So if we look at this diagram lower down, we can see that there's a bulge in the posterior wall or the back wall of the vagina. And if the bulge is lower down, we call this a rectocele. And if the bulge is higher up, we call it an entrocele. So again, the operation is performed vaginally. The incision is in the posterior vaginal wall, so the back wall of the vagina there. And again, the prolapse is mobilized back into a favourable place, and then using stitches to secure it in place, and then the posterior wall of the vagina is sutured. Again, using dissolvable stitches, and again, if a catheter is needed, it's usually removed the following day. Now let's look at different types of surgery. So this is called a pubovaginal sling, also known as an autologous sling or a rectus fascial sling. So it's used to treat stress urinary incontinence. So that's what that stands for, stress urinary incontinence. And that's when there is an increase in intra-abdominal pressure and you may leak on cough, laugh, sneeze, shouting, etc. So that's when this operation would be indicated. So previously, the trust were using a TOT or a TVT, but that requires the use of mesh, which has a national and international suspension at the moment. So the trust are not using mesh and instead using this surgery instead. So it's using your own tissue to make a little sling underneath the urethra, which is your waterwork tube. And often the rectus fascia is used, so they fascia in your lower tummy. So if you have a little look at this diagram here, you can see there's been an incision made in the lower part of the tummy to remove the fascia. So fascia is connective tissue, the things that gum us all together. So a little bit of that is removed and then created to be a sling, and then placed underneath the urethra to give it support. So when you cough, laugh, sneeze, exercise, and that pressure increases in the abdomen, leakage should not occur. And in terms of surgery recovery, the recovery is very similar to a hysterectomy. So now let's look at sacrospinous fixation. So this is an operation that is done to attach either the vault or the cervix to a pelvic ligament called a sacrospinous ligament using a very thick suture called a PDS suture. And it's placed through the ligament, the sacrospinous ligament, generally on the right-hand side. The bowel is on the left, so it's generally on the right-hand side to help to elevate the vault or the cervix. And that PDS suture can take 4 to 6 months to dissolve. And some people that have this surgery can get a little bit of right buttock pain for a few days, which is completely normal and should settle with time. So that's the types of operations that you may be having at the Trust. Thank you very much for listening. And there is another part to the video that goes through post-op recovery. So I hope you can tune into that. Thank you. Bye.